Hi, my name is Kathy Naylor, and I will be discussing esophageal cancer. Esophageal cancer is the 8th most common cancer in the world, affecting over 450,000 people. It is the 6th most common cause of cancer-related deaths worldwide, with 80% of these cases in developing nations. In 2016, more than 46,000 people in the U.S. were living with esophageal cancer, and the occurrence in China and the Middle East was 20 to 30 times higher. Esophageal cancer is 4 times more common in men than women and slightly more lethal in men. While many types of cancer are expected to have a decrease in incidence, the prevalence of esophageal cancer is estimated to increase 140% by 2025. Close to 18,000 new cases were diagnosed this year, nearly 14,000 men and 4,000 women. This is 1% of all new cancers. The number of deaths related to esophageal cancer this year is nearly the same. There are more than 13,000 men and 3,000 women who have lost their battle with esophageal cancer. This is 2.6% of all cancer deaths. Despite advances in diagnostic and treatment techniques, the 5-year survival rate is only 15 to 20%. And 20 to 30% of all patients will have distant metastasis at the time of diagnosis. The 2 most common types of esophageal cancer are squamous cell carcinoma and adenocarcinoma. Sarcomas and small cell carcinomas account for less than 2% of all esophageal cancers. Lymphoma, carcinoids, and melanomas can develop in the esophagus, but they are very rare. Squamous cell carcinoma is the most common esophageal cancer worldwide. Its incidence increases with age and peaks in the 70th decade. Incidence in blacks is 3 times higher than in whites, and it occurs equally in the middle and lower portions of the esophagus. Risk factors specific to squamous cell carcinoma of the esophagus are alcohol consumption and tobacco use. When individuals are doing these in combination, it creates a synergistic effect and further increases the risk of cancer. The pathology behind squamous cell carcinoma, its development begins in the flattened squamous epithelial cells. Damage to cellular DNA decreases metabolic function, which promotes oxidation. Oxidative metabolism produces free radicals, which have a toxic effect and damage all components of the cell. Alcohol is a fat-soluble solvent, which allows easy penetration of epithelial cells by the carcinogens in tobacco, which is an example of the synergistic risk factor increase. Inflammation of the squamous epithelium has been linked to dysplasia, leading to malignant changes. Our second most common type, esophageal adenocarcinoma, occurs mainly in the distal portion of the esophagus. Adenocarcinoma has a greater long-term prognosis after surgical resection than does squamous cell carcinoma, and the 5-year survival rate is 47% versus 34% with squamous cell. Specific risk factors to adenocarcinoma are obesity and gastroesophageal reflux, or GERD. If the GERD is left untreated, it can lead to the diagnosis of Barrett's esophagus, which is a precursor to esophageal cancer. This shows images of individuals with some erosion beginning from GERD, and then a patient with Barrett's, and then you can see here the microscopic changes from low-grade dysplasia to high-grade dysplasia, and then progressing to malignancy. The pathology of esophageal adenocarcinoma The changes initially develop in the mucus-secreting glands of the esophageal lining. Chronic gastric acid and bile at the gastroesophageal junction can damage the columnar epithelia, which leads to changes in the cells that, if left untreated, can progress to abnormal precancerous cells or lesions. Fat deposits contain fat and inflammatory cells, which release cytokines, signaling an inflammatory response and promoting tumor growth. This is why obese patients, especially those with excessive visceral or intra-abdominal fat, are at greater risk of esophageal cancer. Again, some images of esophageal tissue from normal, healthy, progressing to cancerous lesions with prolonged untreated acid exposure. Risk factors in general for esophageal cancer: smoking or secondhand smoke, alcohol consumption, the use of smokeless tobacco products, drinking hot temperature tea and coffee, red meat consumption, low intake of fruits and vegetables, poor oral hygiene, low socioeconomic status, age, gender, and race can play a factor, obesity, Barrett's esophagus, history of GERD, and achalasia, which is a rare disease of the esophagus where the lower esophageal sphincter fails to open during swallowing, and this leads to the backup of food into the esophagus. There are also some occupational factors to be aware of. Individuals working in environments with prolonged exposure to asbestos, certain mineral spirits, toluene, and synthetic adhesives, along with other chemicals, are at risk of causing chronic irritation to the esophagus that can lead to dysplasia over time. The function of the esophagus is to connect the throat to the stomach. It's a tube-shaped organ made of circular and longitudinal muscles, which move food, liquid, and saliva to the stomach using the involuntary peristaltic wave motion. The esophagus runs through the middle of the thoracic cavity and is typically 25 to 30 centimeters. It has two sphincters that open and close, which are controlled by the swallowing reflex. The upper sphincter is composed of striated muscle. The lower sphincter is smooth muscle and works with the crus of the diaphragm to ensure gastric acids remain in the stomach and do not damage the esophagus. This is the anatomy of the esophagus. You can see it begins at the back of the throat, at the oropharynx, down through the epiglottis, the thyroid, and cricoid cartilage. It runs along the trachea. Then in the thoracic cavity, it runs along the right and left mainstem bronchus of the lungs. The arch of the aorta kind of wraps around it here. It continues through the abdominal cavity and then passes through the diaphragm here at the lower esophageal sphincter and then into the stomach, which is where it ends. The mucous membrane lines the esophagus and acts as a lubricant to allow food to pass through the lumen more easily. The mucosa is composed of 3 layers. We have the stratified squamous epithelium, and that's the inner lining which allows absorption and secretion. There's a thin layer which is called the lumina propria. It's connective tissue, and it supports the epithelium and then binds it to the outer line tissue. This outer layer here is called the muscularis mucosa. It provides continuous movement, which helps with mucus secretion. Muscularis submucosa here houses glands, blood vessels, submucosal, and myenteric nerve plexus. It makes up the intercircular muscle and the outer longitudinal muscle layers of the lumen. And then we have the adventitia, which is the external covering of the esophagus. This connects it with the outer neighboring structures. It's a fibrous layer composed of loose connective tissue. It contains small vessels, lymphatic channels, and nerve fibers. There are a few common signs and symptoms of esophageal cancer. Difficulty swallowing and hoarse voice that goes unresolved, persistent chest pain, coughing, or heartburn despite treatment with common medications. The American Joint Committee on Cancer developed the Tumor Node Metastatic, or TNM system, which is used in staging esophageal cancer, and it directly affects or determines the prognosis and treatment options. The T staging correlates with the depth of the primary tumor. N staging identifies lymph node involvement. M staging is the presence or absence of distant metastasis. This gives you an example of the T and M staging. In the TNM system, T in situ relates to a group of abnormal cells in the esophagus. It is considered a neoplasm, but precancerous because it has not penetrated through the epithelium and therefore is unstageable. T1 means the primary tumor has invaded the lamina propria or the submucosa. T2, the tumor has invaded the muscularis propria. T3, tumor has grown through to the adventitia. And T4, the tumor has invaded into the adjacent structures. N0 means there is no lymph node involvement. N1 means there is regional lymph node involvement. M0, no distant metastasis. M1 means there is distant metastasis at the time of diagnosis. This chart shows tumor invasion of specific esophageal tissue layers at each stage. The bottom portion shows the common surrounding structures that the tumor will infiltrate in stage T4, all of which are crucial organs and structures, and the reason this is a deadly cancer which needs better screening for early detection. There are specific protocols for treatment based on staging of the tumor. When the lesion is unstageable or T in situ, ablation therapy is recommended. T1 involvement only is diagnosed as stage 1, and surgical intervention is recommended. T2 or 3 involvement only is a stage 2A diagnosis, also treated with surgical intervention. T1 or 2 invasion with lymph node involvement is a stage 2B diagnosis, and adjuvant therapy with or without surgery is recommended. Stage 3 is T3 or 4 invasion with lymph node involvement and has the same recommendations as stage 2B. A stage 4 diagnosis is tumor invasion at any depth with lymph node involvement and metastasis upon diagnosis. There are many tests that can be utilized in the diagnosis of esophageal cancer. Chest x-rays following a barium swallow can clearly outline the esophagus, making abnormalities on the lining very easy to see. CAT scans can provide a more detailed image with cross-sectional images of the body to help determine if the cancer has spread outside the esophagus. MRIs are most often used to evaluate the spread of cancer. PET scans are not as detailed as CT or MRI, but can more definitively identify whether abnormalities are cancerous or not. Endoscopy allows the physicians to see the inside of the body using a small flexible tube with a light and camera on the end. This allows direct visualization of abnormal patches or lesions. It can provide information on tumor size, extent of its spread, and whether surgical removal is a viable option. The upper endoscopy is inserted into the esophagus. The endoscope can also be used to visualize the larynx, bronchial airways, thoracic or abdominal cavity. Tissue biopsies can be obtained during any of these endoscopic procedures, which can confirm cancer diagnosis, type and grade of the cancer, and its molecular makeup. Endoscopic ultrasound uses a probe that emits sound waves and converts them into images. This allows the user to get very close to the tumor, giving a more precise tumor size and spread. Endoscopic mucosal resection, or EMR, is used to remove the entire lesion from the GI tract without taking out the entire organ. This provides pathologists important prognostic information, such as degree of differentiation and lymphovascular invasion. It is thought to be the most accurate and reliable diagnostic test. And if the margins of the tumor are negative in the pathology, then the resection can be curative as well. Esophageal cancer can be spread by direct extension, lymphatic spread, or hematogenous metastasis. Walls of the esophagus are very thin, usually less than 3 millimeters, which allows for rapid extension of the cancer to adjacent structures in the neck and thorax. It also houses 2 separate lymphatic plexuses, which drain extensive amounts of fluid in both directions to the intrathoracic and intra-abdominal lymph nodes. Adhesion of cancer cells can also occur in distant vessels and organs from circulating tumor cells in the bloodstream. This occurs mainly in the liver, lungs, and bone, but can also spread to the adrenal glands, kidney, and brain. Many treatment modalities are available. Esophageal mucosa resection, we already discussed. Ablation therapy with radiofrequency or cryotherapy can be utilized. The ablation can also be done in conjunction with an EMR. Chemotherapy, radiation therapy, combination of chemo and radiation therapy can be done. Surgical intervention and surgical intervention in combination with chemo, radiation, or both. Esophagectomy is the most commonly recommended surgical treatment, and it can be done by transhiatal or transthoracic techniques. Research data shows the transhiatal method is associated with a reduction in operating time, hospital length of stay, post-operative respiratory complications, and decreased early mortality, while the transthoracic method is associated with fewer anastomosis leaks, anastomotic strictures, and vocal cord paralysis. Patients undergoing this method had more labile hemodynamics during surgery, requiring the use of vasopressors to maintain a stable blood pressure, although these findings were not statistically significant. The 5-year survival rate of both groups showed outcomes were not dependent on the surgical technique that was utilized. In 2013, the National Comprehensive Cancer Network developed treatment guidelines, which includes a triple modality regimen of drug therapy, radiation, and surgery. Cancer control research showed chemoradiotherapy followed by surgery and chemo alone with surgery had better survival rates than patients who underwent surgery alone. 5-year survival was the same in patients undergoing all 3 modalities as it was in patients undergoing chemo alone in conjunction with surgery, and these patients that did not undergo radiation showed less toxicities. There are other experimental studies which are unveiling chemoprophylaxis association with common medications in reducing esophageal cancer risk. Non-steroidal anti-inflammatories or NSAIDs, aspirin, proton pump inhibitors, and statins, which are used to treat cholesterol, are all medications that, when taken alone or in combination with one another, have shown reduced risk. The results from these studies have consistently shown benefit, but further research is required before these can be used as a preventive therapy. Currently, there is no gold standard for screening of esophageal cancer. There are, however, guidelines for primary care physicians for determining what patients would benefit from testing. For instance, patients with heartburn 1 or more times per week, not relieved by medication, and persisting for more than 5 years. Long-term use of tobacco products, diagnosis of any form of squamous cell carcinoma related to tobacco use, unresolved difficulty swallowing, diagnosis of Barrett's esophagus, obesity and excessive alcohol consumption are additional factors that should be considered, especially in men over 55. The rapid increase in incidence over the past few decades, along with the aggressive and often fatal nature of esophageal cancer, is gaining the public's attention. April is Esophageal Cancer Awareness Month, and the periwinkle ribbon is the international symbol. The Esophageal Cancer Awareness Association is doing their part by creating a website with easy-to-read information about the disease, risk factors, diagnosis, staging, treatment options, and expertise specialty centers. ECAA has also established public and private Facebook pages, giving another arena for support amongst esophageal cancer patients and their family and friends. It also provides current information on studies and trial opportunities. Several celebrities have been affected over the past decade by this disease. The Kardashians are among these affected, and in April of this year, they publicly dedicated the new UCLA Robert G. Kardashian Center for Esophageal Health. They have committed to launching fundraising efforts for future research and to provide resources for the center's key initiative. The prominence of the Kardashian family becoming involved in the fight against esophageal cancer may open many doors in the opportunity for advancements in this field of oncology.